Hirap ako dating imuko at hindi ako makatindig. Nanghihina na ata ang mga buto ko. Baka may osteoporosis na ako. Kaya, nag-exercise ako, tamang diet at ANLENE.
Research proves ANLENE drinkers maintain stronger bones than
Now, with strong bones, natupad ko pa ang aking pangarap na maging dancer.
Joke lang po!
Nakakuba ka na? Hala, magiging bakekang ka na. Joke lang po. Ang parathyroid ay nagkakos ng osteoporosis by making too much PTH, na kung saan ang katawan mo ay tinitake ng calcium from your bones. Ano nga ba ang PTH or parathyroid hormone? Parathyroid hormone is produced by the parathyroid glands, which are small, paired structures located in the posterior thyroid capsule. They may, however, be located in other parts of the neck or upper chest cavity. Parathyroid gland consists of 4 small glands found at the poles of the thyroid. Parathyroid hormone is produced by the parathyroid glands, which are small, paired structures located in the posterior thyroid capsule. They may, however, be located in other parts of the neck or upper chest cavity. The major physiologic action of PTH is mineral homeostasis. Specifically, PTH is involved in the metabolism of both calcium and phosphorus by the kidney and bone. A complex interrelationship exists between PTH, cholecalciferol, or vitamin D, and calcitonin. For the transport, parathyroid hormone, unlike many other proteins, is transported as a freely circulating, intact, active molecule. The biologically inactive amino acid fragments can be detected in the serum as well. The primary determinant of PTH release is the serum concentration of ionized calcium, considered to be the biologically active form of serum calcium. Other substances that impact PTH secretion rates include: first, magnesium, which has an effect on PTH that both parallels and modulates the effect of calcium on PTH release. Second, biogenic amines like epinephrine, dopamine, and serotonin. And lastly, the vitamin D. Next is PTH has an important role in calcium and phosphorus metabolism. Calcium is a mineral proven to be essential for heart muscle contraction, hemostasis, and cell responsiveness. Calcium homeostasis is regulated not only by PTH but also by cholecalciferol and the thyroid hormone calcitonin. The overall effect of PTH is to raise blood calcium levels through its action on bones and kidneys. In bone, PTH increases bone resorption of calcium into the serum. In the kidney, PTH increases the renal reabsorption of calcium. Next is phosphorus, or rather compounds of phosphate, is in all living cells and participates in many important biochemical processes. The overall effect of PTH is to lower phosphorus concentrations, whereas vitamin D acts to increase blood phosphate. Lastly, calcitonin is produced by parafollicular cells in the thyroid. In general, the overall effect of calcitonin is to decrease blood calcium because of its effect on both bone and renal calcium processing, which is just the opposite of PTH. So in bone, calcitonin inhibits bone resorption of calcium, while in the kidneys, calcitonin decreases the renal reabsorption of calcium, phosphorus, sodium, potassium, and magnesium. Pathologic conditions involving a dysfunctional parathyroid gland most often manifest as hypocalcemic or hypercalcemic states. So, hypocalcemia is classified as either being associated with deficient PTH concentration or being independent of PTH activity. In general, the PTH-dependent hypocalcemic disorders fall into 2 categories: those related to hyposecretion of PTH and those related to tissue resistance to PTH, known as pseudohypoparathyroidism. So first, let's discuss about primary hypoparathyroidism. Primary hypoparathyroidism is synonymous with hyposecretion of PTH. It is caused by surgical removal of parathyroid glands, trauma following surgery or radiotherapy directed toward the thyroid gland. The clinical manifestations are those of hypocalcemia and include tetany or muscle spasms, skin changes, especially drying, brittle hair, hypotension, and GI upset. Next is idiopathic hypoparathyroidism is rare and can be hereditary or seen in conjunction with other endocrine disorders. Lastly is pseudohypoparathyroidism is characterized by a lack of responsiveness to PTH by the renal system or other organ systems, not by a decrease in PTH. Next is hypercalcemia is diagnosed when serum calcium levels rise to greater than 102 milligrams per liter or are sustained at levels greater than 100 milligrams per liter. Symptoms range from no symptoms to manifestations of polyuria, polydipsia, kidney stones, acid-base disorders, nausea, stupor, or coma. Malignancy, for example, multiple myeloma, leukemia, lymphoma, and hyperparathyroidism account for most cases of hypercalcemia. For the primary hyperparathyroidism, most often results from parathyroid adenoma or hyperplasia. Additionally, hyperparathyroidism can be associated with other endocrine disorders, collectively referred to as multiple endocrine neoplasia, which involve the pituitary, pancreas, thyroid, and adrenal glands. For the secondary hyperparathyroidism, it is a condition associated with an attempt for the body to compensate for hypocalcemic states. It is commonly seen in patients with renal failure who cannot excrete phosphorus, resulting in a decrease in calcium, which stimulates the secretion of PTH. Under the hypocalcemia, primary hypoparathyroidism, there is low serum calcium and high phosphorus are hallmarks of this disorder. For idiopathic hypoparathyroidism, a very low serum calcium level and a very high phosphorus level are indicative of this condition. Laboratory analysis of parathyroid function involves the determination of various hormone and electrolyte levels. The primary analytes of interest in parathyroid function evaluation are calcium, total and ionized, phosphorus, inorganic, and PTH, C-terminal and N-terminal. PTH levels should always be considered along with serum calcium levels. PTH C-terminal analysis examines the intact PTH molecule and is highly specific for detecting hyperparathyroidism. On the other hand, PTH N-terminal analysis measures both the whole PTH molecule and the amino terminal fragments in the serum. Additional analytes of secondary interest include calcitonin, vitamin D, magnesium, bicarbonate, and nephrogenous cyclic adenosine monophosphate. So, nephrogenous cyclic adenosine monophosphate is under the direct influence of PTH and is a measure of the urinary portion of CAMP produced by the kidneys and excreted by the renal tubules.
Gets ba? Okay, ingat!